Hi, everybody. This is Gail, and I am here today to explain week 7 to you. And again, like I've told you guys, they've changed up the assignments a bit. And this is actually a good change because you don't have to write a paper. You have to write some speaker notes, but it's a nice change. So they are asking you to do 12 to 15 slides on dissemination of evidence, and put some speaker notes in there. And they can be minimal, guys. That's fine. Do what you can do. Just put some outline type notes in there is fine for me. Um, this is nice because it actually talks about how once you do a research project or an evidence-based project, how you can tell the world about it. So when I got my doctorate years ago, my plan was only to get my master's degree. I was already teaching. I had my master's of nursing education, but I decided I wanted to practice. So that's all I signed up for was a master's degree to get my nurse practitioner certification. So at the time, though, this was in, I'd say 2005, they had come up with a practice doctorate called the Doctor of Nursing Practice. So they talked all of us into doing a bridge program. So they said, the new thing is everybody's going to have their master's as a nurse practitioner. That's the minimum level of degree. But you can go ahead and bridge over and get your doctorate and be called Dr. Tucker, and practice at a higher level. But more so because they wanted to get nurse practitioners involved in the dissemination of evidence. The terminal degree in nursing at that time was PhD. So those were the nurses working at the bench, doing research, and then publishing it. So their idea was to get this done faster, to get it from the bench to the bedside. They would teach nurse practitioners about how to do research studies. That way, this is how it was explained to me. The PhDs would do the work at the bench. They would come up with new studies on new medications, on new techniques, new wound care, whatever it was. They'd pass it off to the doctorate nurse practitioner students who then could implement it at the bedside and study the results and then say, hey, this really works, or pass it back down to the bench and say, this needs some more work. It didn't really work for us. So that's how I came to be a Dr. Tucker. And it was a very interesting process. The idea of shortening that period from bench to bedside to less than 10 years actually started to happen. So what we did as nurse practitioners is when we would go to a conference and we'd hear about a new therapy of some type, we would then go back to our own population, like you guys are doing in your studies, and implement what they did at the PhD level, their published research. We'd implement it at the bedside and then publish or present at a conference. And so it was very interesting to do. And this is kind of what they're asking you to do. Now, to disseminate evidence was really a scary thing for me. I didn't want to put what I was doing out there to anybody because I was an amateur, kind of still am. And I didn't want to put it out there for any critical, smarter person to evaluate and say, hey, her methods weren't right. This doesn't work. So I started out small, and I was living in Kansas at the time, and I had done a study on triage and training my ER nurses because I was the educator. I was training them to do the 5-level ESI, to increase our throughput because we were building a new emergency department. And so we did this, we increased our throughput. The nurses hated it because we were working out of the old ER when we put the new triage system in place, which was straight back jack. As soon as a patient came in, you put them in a room. There was no waiting room time. Even if we had to use a hall bed, it was straight back jack. And this was really hard, and they really hated me for a while. But once we opened up the ED, the new ED, and we went from let's see, we had 19 beds in our old ED in Lawrence, Kansas. When we built the new ER, we went up to about 42 beds, and then it made sense. And they had already practiced it, and it worked. So I published that, and then went on to publish or I didn't publish it, I guess my dissertation. But to go on and do the work for my dissertation was working with geriatric urosepsis, because these were kind of the forgotten people. They weren't sexy in triage. Sometimes they just presented with an altered mental status, not a localized one. So it wasn't stroke, so they didn't get a straight back jack. Geriatric people have muted vital signs. They're on beta blockers, so they don't increase their heart rate to meet the sepsis criteria. Older people generally don't run a fever till they're about ready to die. If you measure 105-degree fever in an 80-year-old or 90-year-old, they're about ready to crash on you. So when they come in with urinary tract infection, it takes a while for them to come in. They don't feel the normal urinary frequency that we do when we're 30 years old. They don't run a fever. They don't increase their heart rate. They don't do anything. Their first sign is usually altered mental status, with maybe some nausea, maybe some vomiting, maybe they fell once. They stop taking their medications because they're nauseated, right? They stop drinking, so they then get dehydrated. Their sodium goes down, and they become more encephalopathic, meaning an acute encephalopathic is what I mean. So an acute change of consciousness, acute state of mental status, codes better as acute encephalopathy. So that's what we would call it. But we were missing these people, so they'd sit out in the waiting room forever, and they'd get sicker and sicker and sicker. If they were out there for 4 hours, by the time we got them back, they were almost not salvageable. So that's why I wanted to work on the triage of geriatric people to increase the sensitivity. Although we were using the ESI, it wasn't sensitive for geriatric septic patients because they didn't flip the switches, which were increased heart rate, increased respiratory rate, all these things. So I tweaked the triage system a little bit to include an acute change in mental status, not focal, not localized as in a stroke, but any acute change in mental status. And we picked up a lot more sepsis patients. We picked up a whole lot more, and we saved lives. The idea was not just to change that in our locale, but to spread the information on that. And at the same time I was doing my work, there was a lot of work on how geriatric patients are under triage, and they just don't meet the criteria for triage or for sepsis protocol. So what I wanted to do was tell people about it. I wanted everybody in every ER to quit ignoring these people. All the ER nurses want to work with MI patients, with stroke patients, with trauma patients. Geriatric patients aren't sexy, they aren't fun. They can't tell you what's wrong, they can't move, they can't walk, and they're a lot of work. So I wanted to tell everybody that no, these are sick patients, we can save them, and this is what you need to look for. It's not what we traditionally look for. One of the places I started was just my state nurses magazine. That was an easy one to get into. They were begging for people to publish. So I simply worked with another colleague because I didn't consider myself a really good writer. And so she was a great writer, so I partnered up with her, and we got published in the Kansas Nurse. I sent that in then to the Emergency Nurses Association, and we did a poster presentation at a conference. And then that moved on, and I went ahead and published in the Emergency Nurse Journal, or the Journal of Emergency Nurses. And with that, I scored a scholarship. It was like a $1,000 scholarship to complete my doctorate. So this is good stuff, but you honestly have to start somewhere, even if it's a newsletter. If it's your state nursing, or if you're a respiratory therapist, whatever your state professional magazine is or newsletter, start there. And then move up to your professional organization and get more comfortable with it. And then move up maybe with whatever your professional journal is. There's professional journals for administration, for respiratory therapy, for physical therapy, for nurses, of course, for anything. So that's how I did it. You always have to come in with the cleanest draft that you have of your project, okay? Have several people read it, proofread it for you, get lots of edits on it, get it as clean as it can. And the interesting thing is that you have to use whatever formatting guidelines they want. So I think for Emergency Nurses Association, it was strange. You would think for all nursing they use APA because that's what we're trained in school. And for some reason, I don't think it was that. I think it was I think it was American Medical Association. They have their own formatting. So just like APA, AMA has their own, and you have to format your references and your in-text citations in a certain way. So you have to go on that journal website and you see what their formatting guidelines are, how many words you can send in. Then it goes in, and you wait weeks, maybe months, and then they'll tell you, hey, you're selected. Or they'll send it back to you and go, you're close, we need some revisions here, work on this, send it back to us. So then at some point, if they're interested, you'll say, okay, we're interested, we're going to send it out for peer review. So remember how I tell you guys you all have to get articles that are peer reviewed? This is what it is. My article for Emergency Nurse Journal, or Journal of Emergency Nursing, was sent out to peers. They were other nurses that had published before, subject matter experts, and they looked over my article. They then sent in the revisions they wanted or clarifications, and I made those revisions. It took about 6 months to a year, and I got news that I was published. By the way, you don't get paid for this, none at all. I got published, and it showed up 6 months to a year later. So you can already see how this delay, even let alone the research itself, how the delay in publishing can happen. So more years again, from bench to bedside before people really hear about it and can implement it in their own population. All very interesting stuff, a great process to go through, kind of unnerving. But once you get published, then you start adding that to your CV. And it's wonderful. I do recommend not changing your name. I was married at the time and then divorced. So all my publishing is under Shashelsky, and it's not under Tucker. But that's okay. It still goes on your CV. So that's all good when you want to go get hired somewhere that you've been published. Doesn't matter where. They just like, wow, you've been published. So the bigger worldview of this is that you're disseminating the information. Whatever you learned, you're passing on to other people, and then they may decide to implement it in their own population and try it out, or they may cite you. Some people have cited me in their own articles that they wrote. Like when they did their lit review, they went and used some of my stuff and put it in their article. So I got cited. It's really kind of fun. So this is what we're talking about, is how you're going to disseminate your information, either to publish it, or to go to a conference and present. You can present in person. You can present poster. Usually they tell you what they want you to do, what their needs are. But I just wanted to let you guys know a little bit about that. You're in week 7. You're almost done. I'm excited for you. You're going to graduate very soon. Just hop through this hoop, and then you have your final project, guys. And if you have any problems, call me. I'm in school too. I know what it's like. Last week I had a heck of a week. I didn't do replies to one discussion question. First time ever in my life. I said I have to hand off one thing, and this is it. And I didn't do them. So I understand, guys. Life gets very full. You take care. God bless all of you. If you need help or a pep talk, call me. Maybe I need a pep talk. Call me, and we'll discuss. Bye-bye. Take care.